symposium, I think we'll start. If we are ready, we'll just start.
Okay, okay. Yes, Dr. Vidyut.
Should I start?
Oh, yes, ma'am. Yes, please.
Okay. So, good evening, everyone. It's my pleasure to welcome you all on behalf of Women Mental Health Psychiatry Subcommittee, Psychiatric Society Western Zone, Women Mental Health Subcommittee, for this very first webinar of our subcommittee of this new season. We have with us Dr. Mishra, sir, our president, who has joined from Morocco, who is there for the World Congress of Social Psychiatry. Our chairperson, Dr. Ritambara Mehta, madam, and Shubhangi Parkar, madam, is yet to join, I think. So for this opening session, we have a very important and interesting topic, exploring sexual dysfunction in women with psychiatric disorders. As we all know, sexual health is an important aspect of our overall general well-being, yet it is often neglected, and maybe because of the hesitation and shame surrounding the topic and due to the cultural factors, very few people seek help for these complaints. And female sexual dysfunction is even less talked about. So today's topic, female sexual dysfunction in psychiatric disorders, is even more complex. And so to throw the light on this complex intersection, we have with us today Dr. Veda Shetagiri, a young and dynamic psychiatrist from Bengaluru, who will enlighten us on this topic. So before I hand over to Dr. Ritambara Mehta, madam, our captain of WMH subcommittee, there's a small request. Everyone, please keep your microphones mute. Everybody is already on mute, actually. And you can put your questions in the chat box so that our speaker can answer your queries after the session. Over to you, Dr. Ritambara, madam.
Hello, thank you, Dr. Vidyut. Good evening to all of you, and welcome to this first Women Mental Health subcommittee of this West Zone. This webinar is actually held on 3rd of the Friday of the month. Every month, most probably, we will be having this webinar. But before we start, as a chair, let me introduce our subcommittee. But before that, I welcome Dr. Kshirod Mishra. Sir, welcome. And thank you very much for giving us this opportunity. Along with Dr. Mishra as president, we have Dr. Parag Shah, who is also the vice president of West Zone, and Dr. Fai as secretary. Earlier also he is continuing. Dr. Nakul and Dr. Hina Merchant as editor. I thank these office bearers to give us as subcommittee this opportunity. In our subcommittee, these are also many women are there. Last year we all were women. This year we have one male member also. We wanted to have more male members, but somehow we ended up with all the females this time also, mostly. From the West Zone, we have our advisor, Dr. Shubhangi Parkar. Welcome, madam. She has been an ex-dean and professor head of SAT GSMC Medical College. And as EC coordinator, we have Dr. Nimesh Parikh, who is currently professor head at NHL Medical College, Ahmedabad. As convener, you have already seen her, Dr. Vidyut. She has been a consultant psychiatrist from Amravati. Other than this, our subcommittee has 6 members, myself as chair, and Dr. Shobha Nair. She's actually the head of Bark Hospital Psychiatry. And also, we are lucky that she is the president of Bombay Psychiatry Society. And maybe we'll be doing some programs with the society. Dr. Krishna Patel, she's professor head at Sal Hospital and College, Ahmedabad. Dr. Nilima Shah, she is associate professor again at NHL Medical College, Ahmedabad. And Dr. Alapi Prajapati, she is our assistant professor at the GCS Medical College, Ahmedabad. and Dr. Ela Vatsala Sharma. She is a consultant psychiatrist, Vadodara. All these women, let me tell you, they are very enthusiastic and very interested in the women's mental health. And so, look forward to all these webinars. Especially, we are concentrating this year only on women. So, we'll have more and more programs which may interest all of you. So that's about our subcommittee. Today, being the first webinar, we have kept a topic pertaining to very core psychiatry, that women who have psychiatric disorders, and they also might have sexual dysfunctions, but many times normative sexual functions also we are not talking in the society. What about the psychiatric disordered women, how they must be talking about, or they might be experiencing, and how we can assess as psychiatrists and mental health professionals? That's a very very interesting topic, and we all must actually know more about it. So for this, we are lucky to have as a speaker, as a guest speaker, Dr. Veda Shetagiri. So, Madam, if you can put her introduction slide. Yes, she has done her MBBS and MD from Jain Medical College, Belgaum. And for last 15 years, she is in the academics and currently working as professor at East Point Medical College, Belgaum. Let me tell you that she is a very apt speaker for today, because she has been a woman representative from the South Zone. She has represented women all over. You all know actually through I exactly don't know what's it called, IPPL, the cricket team also of the women. So Dr. Veda is always there, cheering and promoting women. So she has been a convener at IPS, PG Academic Subcommittee. Also, she's a co-chair at IAPP for Women and Mental Health. And she's an ex-convener at IPS South Zone, again, women representative. And currently also she is EC member in IAPP as well as IPS Karnataka chapter. Also, she is a section editor for women's mental health for IJPM. So, what an apt speaker, Veda, you are. And last, no, but not the least, she has actually finished her fellowship on psychosexual medicine at JSS University, Mysore, very recently. And she has been very vocal speaker on these topics. So, I welcome you, Veda, and I'm sure you're going to do justice to the topic. And Dr. Vidyut, if you want to say something more, and then over to Veda. Thank you. And before that, Dr. Mishra, would
Can
you like
Dr.
to say
Mishra
something?
sir,
Yes.
can you, sir,
Good
are
evening,
you
madam. I'll
there?
not take much time.
Dr.
I'll
Mishra
not
sir?
take much time because I'm in a symposium here, madam. So there
Yes,
will be
sir.
disturbances. So I
Please.
welcome all the team members for the excellent work going on. And
Yes.
and Veda will be a good, excellent speaker. And I welcome all the people who have been gathered for this program. And thank you all, because because in the symposiums I'll not disturb you much. Thank you very much. I could join from the distance. Thank you. Thank you.
So
You can continue.
your presence itself is very encouraging for us. Thank you, sir.
Thank you
Thank you.
so
Thank
much
you.
for
So much,
joining,
sir.
sir.
Yes.
Thank you, sir.
Yeah.
Yes.
Yes, thank
Thank
you
you.
so much for joining. Yeah, Dr. Veda, I think you can start with the presentation.
First of all, I would like to thank Psychiatric Society of Western Zone Women and Mental Health Subcommittee for this wonderful opportunity. Thank you, Ritambara Mehta ma'am, and Dr. Vidyut for your kind introduction. I hope to do this justice to the given topic for today. I'm the opening batsman for this year as well now, since I'm beginning my webinar for this first Women and Mental Health section. So let me just tell you as to why this topic is very pertinent and why all of us need to know about it more. So, as we all know, sexual health is very much integrated to mental health. So, WHO also recognizes that sexual health is a basic human right. And it has been noticed with the available studies that there is very high prevalence of increase in all types of psychiatric disorders. The sexual dysfunction that we see goes on to around 2 to 3 folds increase when it comes to depression, anxiety disorders, PTSD, social anxiety disorder, bipolar disorders, or schizophrenia. And many a times the patients are undiagnosed, untreated, basically because of social stigma and cultural taboos that exist in our society, as we all know. So many a times this female sexual dysfunction, the presenting manifestation of an underlying mental illness itself could be loss of libido, or it could be intimacy related issues or avoidance when it comes to anxiety related disorders as well. So, for example, sexual aversion may be a presenting manifestation of a mass trauma or a person who is a trauma survivor. Intimacy issues could be definitely seen in patients with PTSD. Then, a very important, one more important concern is psychotropic medications, especially that we come across sexual dysfunction because of psychotropic medication. So,
Excuse me,
which
madam, have
again,
you shared your slides?
yeah, how's that? Yeah.
Okay, now that would be shared.
Are you able
Oh,
to see
yes.
now, ma'am?
Yeah.
Yeah, that's great. Please.
Yeah.
Thank you.
Yeah.
Thank you.
Thank you,
Yeah.
ma'am.
All right.
It is full now. Dr.
Yeah,
Veda,
thank
now
you.
it is full. You can start.
Okay, sir. Okay, so the outline of my presentation that I would be doing today I've already given an overview of the problem and I would discuss more about the magnitude of the female sexual dysfunction that lies with the underlying psychiatric disorders. Let's try to know about the epidemiology, the etiology, and the clinical features. How do we assess and then how do we manage such type of cases? Uh, Before we go to the topic in particular, I would just like to brief you with certain basics, like female sexual response cycle, the EPOR model, which was earlier given by Master and Johnson's, which included the excitation, plateau, orgasm, and resolution phase. Then came the DEOR model that was given by Kaplan. Here, the desire was given more importance over excitation, and excitation was clubbed with the plateau in the second stage. And so this was called as DEOR model, which had come in 1979. Following this, we had Whipple and Prash Magyar, which was a linear model that consisted of 4 stages, namely seduction, wherein it is more about desire and attraction, sensations, that is excitation and plateau, surrender with the orgasm, and reflection, that is the resolution. Then came the last, that is the biopsychosocial model, which is the most accepted model by Rosemary Basson in 2001, which postulated a circular type of model in which it gave more importance even without a desire. This model basically was given for partners, those who are in a long-term relationship, which states that the closeness between the partners increases the effectiveness of a sexual arousal, which definitely results into orgasm. So sexual neutrality can occur because of a sexual stimulus resulting into a sexual arousal, and then the sexual desire amounting to sexual satisfaction, emotional intimacy resulting into sexual neutrality. Then this is the pictorial description of the female sexual response cycle. Then we have ICD-10 and ICD-11 along with DSM-5. Here, the female sexual dysfunction is based on the dimensional view as well as the presenting manifestations, as we all know. So in ICD-10, it was classified under mental and behavioral syndromes under sexual dysfunction of non-organic cause, where we have category of lack or loss of sexual desire, failure of genital response or lack of sexual enjoyment, orgasmic dysfunction, sexual aversion, vaginismus, and dyspareunia. In DSM-5, they have subclassified this under sexual dysfunctions, that is, female sexual arousal disorder or interest disorder, male hypoactive sexual desire disorder, female sexual interest or arousal disorder, female orgasmic dysfunction, and vaginismus and dyspareunia are now classified under genitopelvic pain and penetration disorder. In ICD level, this is classified under conditions related to sexual health, that is hypoactive sexual desire dysfunction, female sexual arousal dysfunction, orgasmic dysfunction, and sexual pain and penetration disorder. So this now DSM-4, to just summarize it, under female sexual dysfunction, it is classified under sexual desire disorder, sexual arousal disorder, orgasmic disorder, sexual pain disorders. Under sexual desire disorders, it is hypoactive sexual desire disorder and sexual aversion disorder. Whereas in sexual pain disorders, that is the ICD-10 had classified it as aversion disorder, so dyspareunia as well as vaginismus. In case of DSM-5, that is the new classification, we only have three categories, that is sexual interest or arousal disorder, orgasmic disorder, genitopelvic pain, and penetration disorder. So why, as I was telling you in the beginning itself, is there a need for the evaluation of female sexual dysfunction in case of psychiatric disorders? Yes, the answer is yes. Why? Because there is high prevalence of female sexual dysfunction and it affects around 41% of reproductive age of women globally, with psychiatric patients experiencing anyway around 2 to 3 folds of increase in the rate of female the rate of female sexual dysfunction that can even go up to 80% when it comes to schizophrenia like illness. There are certain specific disorders in psychiatry where exactly there is a bidirectional relationship. That is, depression is one of the such disorders. As we say that the underlying sexual dysfunction can be a presenting manifestation of the underlying psychiatric illness itself. So, a lack of desire or lack of libido itself could be a presenting manifestation of depression. Depression itself can cause anhedonia, which results into blunted desire. So, untreated FSD patients can definitely predict antidepressant induced non-adherence and so on when the patient actually has manifested with depressive symptoms and we treat the patient with antidepressants. Certain antidepressants are notorious enough to even aggravate the underlying problem. So which one actually was the primary disorder that manifested early, whether it was the cause or the effect is not clearly known unless otherwise a detailed history is being taken. Now, many a times the patients are also illiterate and they really do not know exactly which one coexisted or whether the problems coexisted or which one preceded the other. In case of PTSD or trauma survivors, they also develop avoidance via, because of the sympathetic overdrive or sexual numbing, which results into over a period of time treatment resistance. Psychotropic induced ST, as we all know, antidepressants, SSRIs, the SNRIs, and most of the other psychotropic agents also, like typical antipsychotics, atypical antipsychotics, and some of the mood stabilizers are all very well known to cause treatment enhanced sexual dysfunction. So antidepressant can increase the incidence of female sexual dysfunction in around 30 to 50% of the class of patients. Now, this itself can become a treatment resistance marker as well. Like, for example, if the patient continues to have this female sexual dysfunction, even though he or she is in, let us say, remission, or there are some residual symptoms that are left over, that can result into, non-adherence and compliance with the patient becomes very, very poor. So there are chances that the patient can actually go into, a state of treatment resistance as well. And because these sexual related problems are also partner related, there can be, in long term, lot of IP issues with the partner. And then it indirectly affects the quality of life, which can result into loss of intimacy, can result into marital breakdown, relationship crisis, social isolation, and again worsen the psychopathology. So it is more of a vicious cycle. And then when it comes to, clinical and ethical imperative also, many a times we ourselves are very much hesitant to ask this sexual functioning in our day-to-day routine OPD, unless otherwise times the patient opens up, we really don't feel comfortable asking these questions. Sometimes it is physician related, sometimes it is the patient related as well. Many a times we see that the patient only a patient has presented to the OPD. We never even get to actually interact with her partner as well. So there are so many lacunae that are there in the clinical settings itself, which can come in the way of diagnosis as well as treatment. Now, for Indian women, especially, women view sex as a marital duty and not pleasure. So many a times the patients are not, very much open about the problems that they go through. So usually, anytime the illness related sexual dysfunction is always before treating that underlying illness, it is always in sync with the illness. The impact on the desire component of the sexual response cycle is usually low and orgasm is less affected. But in case of drug induced SD, it is usually after the initiation of the treatment. It is very much dose dependent. Whenever you have escalated the dose, or there is more than 2 drugs, more than what is required is been going with the for the patient for a really long time, then the chances of drug induced ST is very high. And here the desire component is always often preserved generally, and but the orgasm aspect of it gets markedly affected. Now, as I already told you, in general female population in the reproductive age group, it is around 40 to 45% with the available data, whereas in psychiatric populations with the underlying psychiatric disorder, it varies actually from 50 to 90%, as high as 90%. So in depression, invariably 50 to 70% of the people report sexual dysfunction. In case of schizophrenia, around 30 to 80% of the women are affected, and these values are also highly variable because of the different types of instruments that are available, or the scales that are available for the Indian population. Now, coming to the bipolar disorder, anywhere the rates can go up to 34 to 78% across mood states. Again, female sexual dysfunction is more noted with respect to depressive disorders. PTSD up to 80% in patients, those who are trauma survivors. Now, FSD cannot be understood through a single lens. That means there is a biopsychosocial approach. It is not just a woman comes to the clinic, I have taken the history and I'm done with it. So it really requires a proper consultation liaison, a proper assessment, as well as appropriate investigations and management. And it is going to be for quite some time. It is many multiple visits will be necessary, and patient needs to be involved with psychosocial interventions as well as the medications that are available. Especially when it comes to female sexual dysfunction, it is mostly because of the anxiety related disorders or underlying mood symptoms. So hence we have to deal with the patients by giving them more time and involve them into many of the therapies that are available. Now, in case of depression, as we all know, it has a bidirectional relationship. So usually depression is of late seen when patients, those who have invariably diabetes mellitus and even cardiovascular disorders. So the what is being known is all three of them can together coexist in individuals, can result into increase in the chances of urinary tract infection that can again enhance the underlying female sexual dysfunction. So the underlying manifestation of depression as a presenting manifestation itself could be loss of libido or reduced desire and arousal sometimes. So the severity especially correlates with the depression severity. As we all know, anhedonia, fatigue, negative self-worth, and psychomotor changes itself can result into each of the sexual problems. Like anhedonia can result into loss of pleasure, fatigue with reduced energy levels, not willing for really for intimacy, negative self-worth because of the past events, ruminations, going into avoidance, and psychomotor changes resulting into no mood upliftment and arousal difficulty. Coming to the neurobiological mechanisms, as we know that decrease in serotonin always regulates or affects the arousal as well as desire, because it is inhibitory, and decrease in the dopamine, again there is no reward, so there is reduced motivation as well as the pleasure. And depression, definitely there are three changes that usually occur, that is HPA axis dysregulation. There is also autonomic hyperarousal state at times when it is coexisting with anxiety symptoms. And there are some hormonal changes also, especially thyroid impairment, which is most commonly seen, can all cause, can result into female sexual dysfunction. So, female sexual dysfunction in case of depression may predate the onset of depression itself. So, it can persist even after the mood symptoms have completely resolved. And it impacts, as I told you, treatment adherence as well as recovery. Sometimes even the patient may go into treatment resistance as well. So, as I explained, neurobiological changes, the medications, once the patient has been started on an antidepressant, the antidepressant molecule, which has the propensity to cause sexual dysfunction, definitely increases the chances. So, we need to be very watchful about the underlying symptoms and not too many medications on the chart. Give it for the time period that it is required and explain to the patient as well that these are the likely side effects that are to be seen, or that can be, that can multiply to 2 to 3 folds in the coming follow-ups. So we need to psychoeducate basically the patient whenever he or she manifests with mood disorder, especially depression. So sexual dysfunction can also be because of relationship strain, already existing relationship strain, or there is a lot of distress and stress that is going on between the couple, and everything amounting to reduced quality of life. So it is not just the neurobiology, but psychological factors like low self-esteem, body image issues, IP issues with the partner, medication related side effects, and the core symptoms of depression itself, which can trigger the underlying female SD. Now, female sexual dysfunction in return, if at all it has manifested, can also cause psychiatric condition, underlying psychiatric condition to get worsen. How is this possible? This is because there is heightened anxiety as to why I'm not able to perform, or there are so many questions on the board that I'm not able to answer for the same. I was not like this before. Why is this now? And there's so much of avoidance between the partners, resulting into a lot of relationship conflicts, and then amounting to isolation, and then medication non-adherence. So the treatment also runs for a really long course of time, and increase in the depressive symptoms, which comes in the way of prognosis. Now, this is a beautiful chart that actually has all four domains of biopsychosocial factors that actually impact the underlying sexual dysfunction. To mention a few, that those are psychodynamic factors, as we all know from Sigmund Freud, who told us about all unresolved conflicts, that is penis envy, then castration anxiety, and so on. Then there is so much of repressed and internalized shame, guilt, anger. Then defense mechanisms that are most commonly used, distorted views of self and close others, and then negative affect, which is basically negative affect, that is the social learning theory and cognitive behavior theory, wherein a child learns, most of the things from their parents basically, and that is through imitation. But if at all in the childhood he has observed all these negative thoughts pertaining to sexual functioning, so that is going to in later life influence the while performing, or to carry out the sexual activity as well. So the underlying changes in the hormones, neurotransmitters, physical injuries, all these biological factors, along with gender stereotypes and your social expectancy as well, from the family members, from the partner, from so many things actually contribute. And as you can see all these arrows, we see that there is a bi-directional link, and they one amounts to the other. So sexual dysfunction can result into depression, again Depression can lead to anxiety. So this is what is the vicious cycle that is all about. So whenever we are dealing with female sexual dysfunction, we have to deal with all these four components, and we have to, formulate the case in such a way that we try to sort out the factors, psychodynamic factors, social and cultural factors, cognitive or behavioral factors, and the biological as well as physical factors. Now, there are some additional risk factors also that can be seen in patients with sexual dysfunction in case of depression. So there are something like chronic medical conditions, comorbidities that usually are seen with depression. Body image concerns can be there. Patient has some, cancer-like illness and is on chemotherapy or radiation. There is a past history of sexual trauma or abuse, and there is past surgical procedures also which the patient has undergone. Along with that, there could be even psychological factors like another psychiatric disorder per se, very commonly social phobia, or the patient is on those of the drugs, medical disorders for which these underlying medications can also result into SD. And most commonly, those are antihypertensives, as we very well know, beta blockers, as well as spironolactone. Then he or she could be using opioid as well as alcohol use. So substance abuse history is also equally important. Then there is already underlying performance anxiety and menopause relationship issues as well. So, female sexual dysfunction, when it comes to bipolar disorder, we all know that in manic or hypomanic phase, there is always an increase in the sexual desire as well as activity, which we call it as hypersexuality. Sometimes there is sexual aggressive behavior also seen, that is impulsive sexual behaviors, and there is a reduced judgment. So risky encounters are there, and sometimes there is high propensity to even acquire, STDs as well. Now, coming to depressive phase, as we know, there is decreased desire and interest. Arousal related difficulties are very common, and orgasmia again, although it is not reported much, and similar to unipolar depression pattern. And in euthymic phase, variable sexual functioning, sometimes medication effects can be prominent. There will be, relationship strain from past behavior, so which can come in the way of performance as well. And residual symptoms, as I told you, even if the mood symptoms have come under control, these residual symptoms can definitely impact intimacy. So treatment considerations, as we know that mood stabilizers, lithium and valproate often contribute to FSD. Atypical antipsychotics have significant sexual side effects. So balance mood stability with good sexual functioning and improve the quality of life. So as less as possible for the effective time period is very, very important. So as we all know, 34 to 78% of bipolar patients usually report FSD across the mood states, with medication effects often compounding to illness related dysfunction. Next, coming to schizophrenia. When it comes to schizophrenia, I told you there is a wide range of prevalence that has been reported. Although there are not too many studies in any of these which I am explaining, there are many studies that have been done on the male population, but very less is known still from the female perspective. So this is one of the upcoming area for research to be taken up by all of us, especially from India. The data which is available is very feeble. So in case of schizophrenia, with the available data, it says that it can range anywhere between 30 to 80%. And the relationship could be, multifactorial again. The illness itself, which can be because of long-standing illness, duration of untreated illness, coming with more of negative symptoms, and in combination with cognitive symptoms as well, long-standing medication-related side effects itself, and extrapyramidal symptoms also because of antipsychotic drugs with and many a times psychosocial factors are also being attributed. So often underreported due to stigma. To illness related factors, negative symptoms, very important because of apathy and evolution. Cognitive impairment, which comes again and affects the intimacy aspect of the individual, social withdrawal resulting into isolation, and delusional beliefs again affecting relationships because of infidelity issues. Now, coming to antipsychotic effects, as we very well know, the typical antipsychotics are very notorious in causing increasing the prolactin levels. The most notorious is our risperidone. So, most of the times, whenever the patient is on risperidone, haloperidol, or high potency drugs, we have to be very watchful about menstrual irregularities in a female regarding amenorrhea or galactoria. So many, all these complaints, one has to be very, very watchful. Increase in weight gain, hirsutism, and so on. So serum prolactin becomes a marker here to assess whether the patient, along with the history, whether there is any correlation with the increase in prolactin. So we have to switch over to prolactin neutral drug. So now dose dependent effects are seen on all the phases of sexual response cycle. So the psychosocial impact is body image concern, low self-esteem and confidence, and limited sexual education with ongoing discussion. So coming to PTSD as well as trauma related disorders, here the prevalence can increase up to 80% in patients, those who have survived trauma especially. And this could be basically because of changes in the neurobiological process. So that is altered HPA axis, which results into, we know, cortisol dysregulation. Then there is heightened amygdala reactivity, especially the right side of the amygdala, resulting into the fear response and reduced prefrontal control, causing emotional dysregulation. So, what happens? These are the four phases of trauma specific manifestation that I have mentioned. One is hyperarousal state, that is inability of an individual to relax during intimacy. Second is dissociation, so completely gets detached during the sexual activity. There are certain flashbacks as well which are noticed. That is because of, it is triggered by the intimate touch. So they might have had a history of trauma or misbehavior or misconduct or childhood abuse in the past. So avoidance, yes, fear and avoidance of sexual situations. Most of the times, these type of individuals always come up with genitopelvic pain type of disorders. So the manifestation is more or less like vaginismus or dyspareunia. So there is often pelvic floor, tensed muscles as well as guarding, and hence not allowing for a intercourse. Now, when it comes to female sexual disorders, in all other anxiety spectrum disorders like generalized anxiety disorder, social anxiety disorder, what we see is there is, in general, muscle tension, persistent worry that interferes with intimacy, and arousal difficulties that arise due to hypervigilance. So in social anxiety disorder also, there is always being, that fear of evaluation during intimacy, fear of being judged, avoidance of all these sexual situations, and performance anxiety, which is very much there, can come in the way of female sexual dysfunction. Now, neurobiological mechanisms in brief, as we all know that sexual function is controlled by a complex interplay. Here, the most important things that we have to remember is the cortex, the limbic system, as well as the hypothalamic region. So the neurotransmitters basically modulate all the four phases of the sexual response cycle through interconnected pathways. So estrogen, hormonal wise, it is estrogen, testosterone, prolactin, and oxytocin. Estrogen is for vaginal health as well as for a proper lubrication. Testosterone determines the desire as well as the arousal sensitivity. Prolactin inhibits the sexual function when elevated, and oxytocin is very much useful for bonding, as we very well know. Coming to the areas of the brain, hypothalamus, the hormonal control and the arousal, amygdala, the emotional response, the fear as well as the pleasure component, prefrontal cortex, that is inhibition or disinhibition, and nucleus accumbens, that is the reward and the motivation. So sympathetic system usually controls the arousal as well as the orgasm. So excess of activation, as I told you earlier, when it comes to anxiety related disorders, it impairs the function. So parasympathetic wise, it mediates vasodilatation, so hence allows it to for lubrication, and it requires relaxation for optimal function. So serotonin, it is inhibitory hormone. So it decreases the desire, decrease arousal, and delayed orgasm. Dopamine is very much facilitatory, increase in the desire, increase in motivation as well as arousal. Norepinephrine, yes, the effect is complex. It is again phase dependent. So it facilitates arousal and orgasm, and excessive levels can definitely impair, which happens in case of anxiety spectrum disorders. Acetylcholine is facilitatory again and promotes arousal as well as lubrication via parasympathetic pathways. So, sexual dysfunction often results from neurotransmitter imbalance rather than single system dysfunction, and treatment strategies target restoring this balance. Now, coming to psychotropic medications, and in brief about female sexual dysfunction, because they tend to coexist. So I thought I should be mentioning about a little bit about this psychotropic induced sexual dysfunction, although it is a separate topic by itself. As we very well know, that SSRIs and SNRIs are very notorious drugs in causing female sexual dysfunction, and the most common cause of drug-induced FSD, as we all know, is very much seen in around 50 to 70% of the patients, those who have difficulty in desire as well as difficulty in attaining orgasm. So the mechanism wise, increase in the serotonin results into 5-HT2 receptor activation, which will inhibit the dopamine, which is the reward for the reward facilitator neurotransmitter, and the norepinephrine levels, and disrupts the nitric oxide pathways. So there will be delayed or absent orgasm, reduced libido, as I told you, and arousal, and it is all dose dependent effects. So as you go on escalating the dose, it is dose dependent. You get to see the side effects. So higher risks are usually seen with paroxetine, sertraline, citalopram, as well as venlafaxine with the available data. Moderate risk is very much encountered with escitalopram, fluoxetine, and duloxetine, and lowest risk is with vortioxetine and vildacinone. Coming to mood stabilizers, lithium, yes, the prevalence is around 20 to 30%, although in females, there is no clear-cut studies that are available. But with the available data, it is around 20 to 30%. Usually, whenever the patient is on any of the mood stabilizers, either they are clubbed with antidepressants or antipsychotics along with the benzodiazepines as well. So mechanism wise, it is unclear, possibly hormonal, so can result into decreased desire in case of females. Valproate also mainly because of hormonal changes and weight gain. So PCOS like symptoms in women can again result into reduced desire. So hormonal changes basically amount to female sexual dysfunction. Carbamazepine, yes, it can affect the testosterone metabolism as well, enzyme induction, which can affect the hormonal contraception efficacy. Coming to lamotrigine, it has lowest sexual side effect profile. So some evidence of improved function is also noted in few class of patients. So sexual dysfunction from mood stabilizers often results from metabolic effects, especially the weight gain, hormonal changes, insulin resistance, etc., which can rather than from direct neurotransmitter effects. Coming to the benzodiazepines, as we know that generally lower rates than antidepressants are used as a combination molecule. So dose-dependent sedation affects the arousal. So it can come in the way of the act. Chronic use can result into cognitive effects when in terms of intimacy. So coming to the clinical assessment and detection. So this becomes very important. That is the screening approach. So in routine also, we should make a habit of asking about the sexual history, as especially the baseline sexual functioning of the individual, to know as a comparative, before the onset of the illness and after the onset of the illness. So many a times we do not record the sexual history in particular when it comes to mental status examination. When it comes to history taking in psychiatry. So many a times we tend to forget, and the important data is missed. So we should always have a non-judgmental attitude. We should have privacy, and open-ended question should be always be preferred. Like even one or two questions about sexual functioning can can help us to, leading questions can actually help us to explore the problem in the underlying individual. So, like for example, are you sexually active? Are there any changes in the sexual interest or the function that you have noticed since few weeks? So these are few of the questions that you can ask, and there are some validated assessment tools also that are available. I whenever it comes to screening, there is SX that is being used, that is 5 item quick screen, and FSFI scale. And sometimes we also use this female sexual desire scale revised as well to know about the distress in an individual. Then just do the medical evaluation for all the hormonal assessment if at all it is not being done, the LH, the FBS, PPBS, the serum prolactin, thyroid levels, lipid, etc. Then coming to psychosocial factors, yes, detailed history about the partner also needs to be taken, and relationship quality assessment has to be done. Any past history of trauma has to be collected. Now, whenever we do sexual functions, dysfunction assessment, we need to know, as I told you, these 5 or 6 points in mind. One is the pre-morbid sexual functioning. Second is the primary psychiatric disorder, whether it was the cause or the effect. Third, the comorbid psychiatric disorders. Many a times, anxiety spectrum disorders can coexist with depression as well, which can be an add-on problem while even treating the patient. Comorbid physical illnesses because of the drugs that they are on, psychotropic medications itself, and all other concomitant medications. Then medical or physiological evaluations, as I told you. So basic investigations, hormonal profile, detailed sexual history, general physical examination, systemic examination, and pelvic examination is very, very essential. And when it comes to pain-related, genitopelvic pain-related disorders, then you have to always seek help of an obstetrician and a gynecologist for, detailed examination as well. So it is more of a consultation liaison wherein we have to liaise with medicine, surgery, with the endocrinologist, and it's just a teamwork. So, what are the principles of treatment? Just inform everybody about all the available choices that are there, and guide the clients. Okay, and discuss with them the treatment options that are always available with you. Tell them about both the pros as well as the cons. Select the treatment as per the client's choice. Now that you have offered the menu, I'll let them choose what they wish to. Tell them about the pros and cons, and after that, tell them about all the side effects that they are likely to go through, and when are they supposed to be coming for the follow up. If at all there are any new emerging complaints, also that they need to come and discuss with the treating physician. And do not ever deny any treatment in case the patient is unable to get his or her partner for the treatment. So the treatment and evaluation must go on, but you must always see that you must insist the patient. It is good if you get your partner, and because it will help to involve both the couple for the therapy as well. So documentation of the mutually agreed treatment plan is very, very important. Then we usually go by this implicit model, which is very, very important. First, we seek the permission from the client. We give, in next few sessions, we talk about the limited information about the underlying disorder, the cause, and what has happened with the patient, and likely problems that he or she is going to be facing. And then coming to the specific suggestion, that is, we narrow down the choices from pharmacotherapy to, psychological interventions, or both of them, if at all required, to be clubbed together. Last is the intense therapy, wherein the patient has chosen for the particular therapy, and that goes on for many weeks. Now, coming to hormonal treatment of female sexual dysfunction, usually I've just enlisted the names of the drugs that are actually available for treating female sexual dysfunction. So, estrogen is very much available in conjugate form, or estrogen transdermal patch. Estrogen along with progesterone is also available, combined cyclic estrogen combined with progestin. Local estrogen available in the form of vaginal ring or cream, and either in the form of gel or suppository. And There are something called as stir and stir SERB molecules, that is tibolone, which is quite useful, and it's SERB, that is estrogen regulated, selective estrogen receptor modulator, that is ospemifene, that is around 60 milligrams per day. So these are few of the medications that are actually available on board. Coming to the non-hormonal treatment wise, non-hormonal treatment, we have flibanserin, that is around 100 milligrams, which is used in premenopausal women who have issues with decreased desire. So we usually give, it is recommended to give flibanserin for 4 to 8 weeks, 100 milligrams, a single daily dose. And then pre-melanotide, again a melanocyte stimulating hormone analog. This is 1.75 milligrams, which is given subcutaneously 45 minutes before the act. This is given on demand, and the likely chances of hyperpigmentation is high. And this molecule can also result to some amount of somnolence, nausea, and can result into headache as well. So, whenever a patient comes with antidepressant induced sexual side effects, then either a drug holiday can be an option, or you can always switch over to, bupropion or supplement with 150 milligrams twice daily. You can augment the underlying treat the underlying problem by augmenting bupropion. Trazodone is also equally a potent drug which can help in resolving SSRI related sexual dysfunction, given in around 50 to 100 milligrams daily. Then we have sildenafil and tadalafil, although it is less effective in case of females, PDE5 inhibitors, as compared to that of males, but still sildenafil can be given for around 3 to 4 weeks, 25 milligrams to 100 milligrams on daily basis, or tadalafil can be given 20 milligrams on demand, okay, or 5 milligrams of daily can also be supplemented for few weeks. Then we have some multivitamins also, that we call it as Argin Max, wherein we have a combination of L-arginine, ginkgo biloba, multivitamins and minerals, which can also, and many other herbal products also, which can definitely help or augment in the treatment of female sexual dysfunction, as it is known to improve sexual desire. Now, when it comes to pharmacological management strategies, the best thing is switching strategies, as we all know. That is antidepressants of choice, less in causing sexual dysfunction, very well known bupropion, mirtazapine, vilazodone, and vortioxetine. Antipsychotics, yes, aripiprazole, quetiapine, and clozapine are less likely to cause, or they are neutral. Mood stabilizers, lamotrigine whenever appropriate. Adjunctive agents could be, by adding bupropion 150 to 300 milligrams, or buspirone 15 to 60 milligrams. And as I was mentioning you about testosterone as well as estrogen molecule that is available, this can actually help to improve the desire in case of postmenopausal women with low levels. And estrogen definitely helps to improve the vaginal atrophy and improves lubrication as well. So, flibanserin for hypoactive sexual desire disorder in premenopausal phase, and bremelanotide, although it is not easily available in our country, it is US FDA approved. So, limited use in psychiatric populations due to drug interactions and side effects, and not many studies are done from Indian population as well. So, non-pharmacological, yes, we have cognitive behavior therapy, couple therapy, sex therapy, and trauma-focused therapy. Cognitive behavior therapy, as you all know, it addresses all types of negative thoughts that are pertaining to sexuality, helps to reduce the anxiety, which results into, which comes in the way of performance, and helps you to challenge all their negative distortions, ruminations, and thoughts. And the couple therapy, yes, you must always involve the partner while you are taking the patient for the therapy or while collecting the history. definitely when he is involved in the very early phase of treatment itself, can also help to improve the adherence as well as compliance, because he will have his own doubts as to what is happening and why is she not cooperating and things like that. So that can actually improve the IP issues, and he can also know about the underlying problems and can help, or be of more support. So it improves the communication about the sexual needs and address the relationship factors and any conflicts, if any. So, sex therapy, yes, gradual desensitization to intimacy, reduce the pressure to perform, and it enhances mindful awareness of pleasure. So, trauma focused therapy, especially in patients, those who have had a past history of trauma, PTSD related female sexual dysfunction. So, it establishes safety before addressing the sexuality. So, mindfulness based interventions show certain promise in improving sexual dysfunction by enhancing the present moment awareness and reducing the distractions. Now, emerging research and future directions. As I told you, there are many molecules that are into the market, but not here. So, some like bremelanotide, that is melanocortin receptor agonists, oxytocin-based therapies, and selective serotonin reuptake enhancers can be novel pharmacological agents along with nutraceuticals and precision medicine approaches. That is, if at all we can find a biomarker well in advance, what can predict a patient who can actually is prone for developing female sexual dysfunction. Personalized treatment selection, so what fits one, a size that fits one may not fit everybody else. So it is more of personalized choices that they make and they choose from the menu. So it's more of customized approach. And genetic markers predicting medication response. Now, we must have given so many medications, but patient might not have responded as well. So we want to know as to why that class of patient has not responded to X class of drugs, or why it is showing so many side effects as well. So open questions and research gaps that have been there. That is, we need to know, keeping this cultural diversity in mind, for the number of tools that are available for the current scenario. We need to take up more research into this area when it comes to female sexual dysfunction, and we need to integrate this with the as a holistic approach while we deal with the patient, especially giving more importance to their sexual health as well. Summary, and I come to the end of close to my presentation. So, FSD in psychiatric disorders is highly prevalent, something that is not diagnosed, underreported, though it has a lot of impact on an underlying individual's course, prognosis, and resulting into treatment resistance as well, and that which actually requires systematic attention from the treating clinician. So, in first place, make it a routine to take the history, routine screening at baseline, use validated tools, comprehensive evaluation in all the domains, biological, psychological, as well as interpersonal. Ask about the sexual function routinely, ask any medication side effects are there proactively, and collaborate with the other specialists also as and when necessary. Treatment principles are, it is, as I told you, a multimodal approach addressing all the underlying contributing factors. You must take everything into consideration. This can balance a psychiatric stability with good quality of life. And patient preferences always central to decision making. Kindly do not impose on any of the patients for making decisions. So, sexual health is integral to overall mental health and recovery. So, addressing female sexual dysfunction will any day improve the treatment adherence. It can improve the relationship quality and patient outcome. So, before I conclude, these are, it ends with desire. So, D is define the dysfunction. E is evaluate the underlying comorbidities. S is screen the patient using the available tools. There are short tools like ASEX, and if you want to go in detail, FSFI is one of the tools for female sexual dysfunction and easily available also. Initiate treatment, refer when it is complex, and educate and engage. So, Madam, can we start with the MCQs or how do we go about?
Yeah, I think you can start with the MCQs. Then later on we can take the questions, right?
Yeah. So there are a few MCQs that I had prepared. So let's see as to how much of it of you have really I have been able to make you understand. So a 30-year-old woman with major depressive disorder reports inability to achieve orgasm after starting an SSRI. Her sexual desire is preserved. The most likely mechanism is. Are there any responses? Is it reduced
No,
estrogen level?
actually, no, there are no responses.
Okay. The answer is increased serotonergic inhibition of spinal reflexes. A culturally relevant reason for underreporting of sexual dysfunction among women in India is it low prevalence of sexual dysfunction? Is it better coping mechanisms, normalization of distress and gender norms, or higher rate of spontaneous remission? What is it likely with respect to women who are, suffering from female sexual dysfunction when it comes to India? What would be the likely reason?
Yeah,
And it,
B. Many have answered.
is it
C.
normalization of
C.
distress and
Many have
gender
answered
norms?
C.
Yes, it is. Yes, C is the right answer. Normalization of distress, as I
Yes,
told you, and gender norms.
yes. So many have got it correct.
Yeah.
Normalization. Yeah.
What happened?
Any more questions, sir?
Yeah, I have. Just a second. Yeah. According to DSM-5, which of the following is mandatory for diagnosing female sexual dysfunction? Is it presence of a psychiatric disorder, symptoms lasting for at least 3 months, or clinically significant distress or objective impairment on female sexual function index?
Significant distress is the answer.
Yes. So clinically
Right?
significant distress is one of the mandatory criteria as per
Yes.
DSM-5.
Yes.
A woman with panic disorder avoids intercourse due to fear of pain. Desire is intact. The most appropriate diagnosis is what it could be.
What is the question? Can you please repeat?
A woman with panic disorder. One second.
Avoids intercourse. Yeah.
A woman with panic disorder avoids intercourse due to fear of pain. Desire is intact. The most appropriate diagnosis is female sexual interest or arousal disorder, female orgasmic disorder, genitopelvic pain or penetration disorder, or hypoactive sexual desire disorder. Can anyone tell me it is due to fear of pain? So I told you in anxiety disorders, what type of female sexual dysfunction is likely?
C, I think many.
Yes, it is C,
C. Yeah.
genitopelvic pain,
Yeah, C is the answer.
genitopelvic
Many
pain
have.
or penetration
Yes.
desire.
Yes.
Disorder. Which antipsychotic is most strongly associated with hyperprolactinemia related sexual dysfunction in women? This is very easy. We have already mentioned it. Quetiapine, olanzapine, risperidone, and clozapine.
So it is risperidone, right? Yeah,
Yes,
the
it
answer
is
is B.
risperidone,
Yeah.
and we need to actually get the serum prolactin levels done. Rest are all neutral. And wait. Just a couple of more
So
questions
the
and then we are done.
answers are showing that people are attentive.
Yeah. A key clinical feature suggesting medication induced rather than illness related sexual dysfunction is reduced sexual desire. It is medication induced ST. So, how would you know that? Is it because of reduced sexual desire, presence of comorbid anxiety, temporal relation with dose escalation, or poor relationship quality. I told you with escalation of doses, FSD chances are also very high. So C is the correct
C is the
answer.
answer. Many have answered C.
Okay, good. Which of the following best explains anxiety related sexual dysfunction? Is it reduced estrogen secretion, excess of parasympathetic activity, sympathetic overactivation interfering with the arousal, or dopamine in excess? Is it sympathetic overactivation interfering with the arousal? C. Which management
C is the
strategy
answer.
has the strongest evidence for SSRI-induced sexual dysfunction? Immediately discontinuation of an SSRI, or psychoeducation alone, or switching over, or adding bupropion, or adding benzodiazepines? What would you like to do in a given situation? Strongest evidence based.
C.
C. Yes, it is switching over to
C is the
or
answer.
adding bupropion. Yes.
Shailaja
With
Singh
this,
Kargi.
men and women approach sex very differently. Men make love to feel love. Women need to feel love to make love. Thank you.
Yeah, thank you, Dr. Veda. That was a wonderful knock by our opening batswoman. So, very comprehensive and lucid presentation. We are, should we take the questions now? There are not many questions actually. So, Dr. Madan Mohan has asked role of fibanserin. Actually, you have
Yeah.
already spoken
I'll
about
just
it, but
answer
would you
in
like to add
brief, ma'am.
something?
Yeah. It is a 5-HT1A agonist and 5-HT2A antagonist, basically. And it is approved in premenopausal women for treating, HSTD, hypoactive sexual desire disorder. The
Yeah.
usual dosage that is approved is 100 milligrams anytime given bedtime. And it is an FDA approved drug, very much used in US and other places, but not really available in Indian market so far. So that is about flibanserin. But having said that, if this drug is being used for about 4 to 6 weeks, let us say, and if there is no response, then definitely should not consider continuing this flibanserin. That is what it. Yeah.
Okay. Dr. Bhavesh Lakadawala, he has asked what we can do for females opening up for their P6P. What is it actually? P6P is, I could not get it.
I am not understanding what is that.
Psychosexual problem.
Oh, pardon my ignorance. Psychosexual problems. Okay. What we can do for females opening up for their uh, psychosexual problems? Males come, females don't even ask to accompany. Even if asked to come accompany, we know problems are there, but we
What about
don't
use
give
of
patients.
vibrators
Unfortunately, yeah,
in
that's
such
true. That's true.
women who have gone to depression and to sexual dysfunction because of psychiatric disorders?
Yes, sir. Definitely, vibrators, Eros device is very much in place, and it has its own utility in case of patients manifesting with desire related sexual dysfunction usually, and also you used in orgasmic disorders, which women generally don't tend to report because many of them would not have reached that orgasmic phase itself, as it has been studied and
Dr. Veda,
reported.
can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
Sir, your voice is breaking, sir.
Can you hear me?
Yeah, yeah.
Yes, sir. Yes, sir.
Yes, sir, you are audible.
Sir, you were asking me about that Eros device. No, sir. It is a clitoral, basically clitoral
Can
vacuum
you hear
device.
me?
Yes, sir.
Hello?
Yes, sir.
Dr.
Sir,
Veda,
I am
can you
able
hear
to
me?
hear you, sir. Yeah, I understood
What
the
about use of
question.
vibrators
Yes, sir.
For those who have gone for sexual dysfunction
Yeah.
due to use of so many medications for psychiatric disorders.
That can always act as an augmenting treatment to the underlying disorder, I would say. Once the underlying psychiatric disorder is taken care of, and all the drugs that have the propensity to cause sexual dysfunction are also tapered and stopped. And as we all know that this clitoral blood flow can be enhanced by the use of these vacuum pump devices as well, which can help in increasing the sensitivity as well as engorgement of the the genitals, which can help in the treatment of FSD, sir. It can always be of great help. Because the side effects wise, it is very in the sense when we start the patient on hormone replacement therapy and all, the chances of side effects are very, very high, and minimal drug interactions as well. So it is local. It is a localized therapy that can always be used by the women, and I think it is quite safe as well. So side effect wise also there is not much, because you don't add too many drugs on board, and it can definitely be combined with psychotherapy, not just using that therapy individually per se as a monotherapy, but always can be clubbed with psychosocial interventions like psychoeducating. Sometimes in severe cases we might have to club medications, which can even include hormonal therapy as well, depending upon the type of sexual dysfunction. And in females, most of the times, what we observe is it is not just one type of sexual dysfunction that the female manifests with, it is always a combination of more than two. So, both can be there hand in hand. So, we need to look into many of the aspects when a female, manifests with sexual dysfunction. I think Dr. T.S.S. Rao sir can answer.
Doctor,
Why?
we are really happy to have Dr. T.S.S. Rao sir for this webinar.
My
Thank
teacher,
you.
Also,
mentor, and guru.
congratulations,
Hi.
congratulations for your presidentship of South Asian
Thank you.
Societies for Sexual
Thanks.
Medicine, sir. It's really nice
I'm
to have
extremely happy
someone
that
like you
I'm
who is
extremely happy that
authority.
Veda spoke on female sexual dysfunctions, and very nice. In fact, she covered
Yes, sir.
almost all the aspects. Of course, there is one aspect which actually Dr. Sharad Kumar was mentioning.
Yes, sir.
Now, use of vibrators and such other things are actually very strongly recommended in female sexual dysfunctions by sexologists. But we in psychiatric practice now, it is really one of the thing not taken too seriously. I think that is one area we need to consider. Very good. You covered the topic very nicely. And see, in psychiatric disorders, what we need to keep it in mind is actually, as she mentioned, is a bidirectional. One is the illness itself. Somebody responds because of the medicines, they will actually improve in the sexual functioning too. But many of the times, every drug what we use, the problem becomes double. That means treatment emergent sexual dysfunctions are one of the most important area in psychiatric practice. What we need to keep it in mind. And coming to SSRI, compared to males, there is whole data that women respond much more strongly and more significantly. So SSRI-induced dysfunctions are much more commonly reported in case of females than in case of males. And you rightly said there are few drugs to be chosen from the beginning itself. That way one can avoid the development of the problem and then trying to correct it. Now there is a whole range of treatments are available, what we call PDE5 inhibitors and other related drugs, which were not, though of course that is actually off-label use. Still, it has been found useful by quite a few, and data is very favorable for that.
So thank you so much for the insights.
Good, good.
Thank you, sir. Thank you so much
I'm
for
so
your.
glad that you joined the webinar yourself and Dr. Sharad Kumar sir. Sir, thank you so much, both of you.
That's good. Good, good, good.
Thank
Dr.
you, sir.
Shweta is part of our fellowship training program.
Yes,
Oh,
sir.
is it, sir?
Thank you so much for your remarks, sir.
Thank you.
Dr.
Thank you, Dr.
Yeah.
Veda, and thank you, Dr. Rao. As I am outside Surat, I'm really sorry that I'll not be able to keep my video on. But it was an excellent presentation and excellent discourse. And thank you, Dr. Rao, for your presence.
Thank you. Thank you.
Thank you, sir.
Thank you. So should we end the meeting now? Thank you so much, Dr. Veda.
Thank you,
And
Vidyut ma'am. Thanks a lot.
thank you all the participants for joining. Thank you so much.
Thank you, sir. Good night, sir.
Good.
Thank you, sir.
Good night, everyone.
Good night, ma'am. Thank you so much for everything. Thank you.
Thank you. Bye and good night.